I'd like to talk a little bit more about haemoglobin at this point. The graph that we see here is the very standard graph showing the association between oxygen partial pressure on the x-axis and on the y-axis the percentage saturation of haemoglobin. And we can see that as oxygen partial pressure rises, the blood becomes increasingly saturated, and this graph has this classic sigmoidal shape. This, of course, is due to the fact that there are 4 units in haemoglobin, and the binding of oxygen facilitates the binding of the next oxygen, giving us this characteristic shape. One of the things that's worth noting here is that at the levels of oxygen that we would normally find in the alveoli, where the partial pressure is somewhere around 100 millimeters of mercury, the blood is effectively 100% oxygenated. It's fully oxygenated, which is why hyperventilating, where you increase the partial pressure of oxygen in the alveoli, isn't really going to increase the amount of oxygen that's being held by the blood, not to any significant extent. So the blood leaving the lungs is normally, effectively, 100% oxygenated. As you go to the tissues have consumed oxygen, and so the partial pressure is lower, and perhaps in the tissues the partial pressure is maybe 30 to 40 millimeters of mercury, something like that. What we find is that at these lower partial pressures, the haemoglobin is less saturated, and that represents oxygen which is offloaded to the tissues, which they can then use for their respiration purposes. Now, the dotted line here illustrates what's called a right shift of our haemoglobin-oxygen association curve. This right shift can be caused by a rise in the partial pressure of carbon dioxide. It can be caused by an increased concentration of protons, which effectively means a reduction in pH. It can be caused by an increase in temperature, or it can be caused by an increase in a molecule called DPG, diphosphoglycerate. Now, the first 3 things, the rise in CO2, the fall in pH, and the rise in temperature, are all circumstances that you would expect to find in the tissues. For example, in particular, exercising muscle. If muscle is exercising, the carbon dioxide levels are higher. There might be lactic acid being produced, which means the pH is lower. And in fact, the high CO2 will result in a low pH as well. And we would expect the temperature in an exercising muscle to be higher than it would be normally. So within the tissues, we expect the haemoglobin curve to be the dotted curve. The significance of this is that you get increased offloading at the tissues. So if you imagine you're in the lung, becoming oxygenated, you're at about 100 millimeters of mercury on the x-axis, you're towards the right-hand side of the x-axis, and your haemoglobin is about 100% saturated. Now, if you then move to the tissues and there was no right shift, if you take the partial pressure down to tissue partial pressure values, you get a certain amount of oxygen offloaded. But if you imagine that at that point in the tissues, the haemoglobin has been right shifted as well because of the CO2, the pH, and the temperature, then I hope you can see that you actually move to a lower point, and what that means is you're offloading more oxygen than you otherwise would. So the right shifting promotes the offloading of oxygen from the haemoglobin. It's a good thing. One of the factors which people find confusing sometimes when you're looking at this curve is the molecule DPG, diphosphoglycerate. What effect does this have? Well, it also causes a right shift. But the difference here is that diphosphoglycerate is not something which is going to increase at the point where you get to the tissues and then decrease at the point that you get back to the lung. It can't increase and decrease that rapidly. It's actually a byproduct of glycolysis, which is synthesized within the red blood cells according to circumstance. And the particular circumstances in which it's produced include, for example, alkalosis and hypoxia. Now, we would experience these circumstances if we were at altitude. If you imagine you've climbed up a mountain, then because the oxygen levels are low, your peripheral chemoreceptors can detect this, and that's going to translate into an increased ventilation rate. So you start to breathe harder when you're up a mountain. Now, breathing harder, hyperventilating, results in the lung dumping more carbon dioxide. So you're losing more carbon dioxide from the body, and of course that gives you a respiratory alkalosis. And under these circumstances, this molecule DPG is produced in higher quantities. That's going to right shift your curve. Now, you would think that this would facilitate unloading in the tissues, and that's exactly what happens. There's a rather interesting circumstance which can happen if you go slightly higher in altitude. If you think about it, I've said already that going to altitude causes hyperventilation, which leads in turn to alkalosis. Now, alkalosis is a rise in pH, and that would tend to left shift your hemoglobin-oxygen association curve. But at the same time, you're producing DPG, diphosphoglycerate, and diphosphoglycerate tends to right shift the curve. And these effects offset each other. So there's a particular altitude where the left shift caused by alkalosis is offset by the right shift caused by DPG, and as a result, your hemoglobin-oxygen curve is actually in the normal position. So it's quite a nice little adaptive response which allows your hemoglobin to operate normally even under circumstances where the pH levels have changed.